right, I'll go again. Let everybody in now. Hello, everybody. Welcome. Thank you so much for joining us, the Virtual Pathology Student Interest Group here at our Spring Symposium event, the Step 1 Hematopathology Review with the iconic Dr. Mirza. Just a few points before we get started here, just so everyone knows this event is being recorded and will be posted onto our YouTube channel at a later date. And if you have any questions throughout the presentation, please just go ahead and throw those in the chat. Myself, my name's Jerome Givey. I'm one of the event co-chairs for the group. I'll be doing my best to moderate the chat questions as they go along, but we really want to make sure we get through everything. So yeah, without further ado, please, Dr. Mirza, take us away.
Hey everyone, it's great to see all of you in the room today. I'm assuming most of you are studying for Step 1, so good luck. I love HemePath, and so what a great opportunity to be sharing my love for HemePath with you all. I have to give credit to Jerome, who put this review together for me, which is incredible, and then also Emma helped out with the design. So I'm one of the co-founders of PathSig, and in general, we created PathSig because we find that students don't get properly exposed to pathology as a career, and your own interest groups may or may not be thriving at any particular time. And so please, stay in touch with PathSig because it puts on incredible things, and hopefully this review will be similar. So I am a hematopathologist. I'm a professor of pathology and the director of the Division of Education programs in the Department of Pathology at Michigan Medicine, University of Michigan, where I'm the assistant chair for education. And so in my past life, till recently, I've been a HemePath fellowship director, and HemePath really is my love. And so very excited to jump in from it. So I'm also one of the associate editors of the ASH Image Bank, and many of the images we're using are from the ASH Image Bank. This is an incredible resource, the American Society for Hematology, so please check that out as well. So when we talk about hematopathology or hematopoiesis, we have to think about, the ontogeny of how cells grow. So right now, all of us sitting together in this Zoom environment, our bone marrows are working, super active. They're making hundreds of thousands of millions of cells. So by the time this 1 hour is over, we will have created probably thousands of cells, millions of cells, and that's not an exaggeration. So we should kind of remember as we think about considering different types of hematopathologies, the fact that the hematopoiesis starts with a pluripotent or multipotential hematopoietic stem cell, right? And so this is typically what we call a blast cell, an immature cell that now can divide into, broadly speaking, one of two pathways, right? One is the lymphoid pathway, where it will become the common lymphoid progenitor, and then that will split into B cells, T cells, and natural killer cells, right? And so B cells can further differentiate into plasma cells, and that's important to know so that we can consider plasma cell lesions. But that's one big arm, right? So the lymphoid arm, that's one thing. The other arm is obviously the myeloid arm. So there's a common myeloid progenitor, and there are a few variations to kind of how people think about all the terminally differentiated cells. But by and large, you're creating the megakaryocytes, which will make the platelets. You're making the red blood cells, which are also theoretically myeloid cells, right? You're making all sorts of cells that contain granules. So those are granulocytes. Those granulocytes can have blue granules and be called basophils, neutral colored granules and be called neutrophils, or pink or eosinophilic granules and be called eosinophils. We also make monocytes and macrophages. And so overall, I think it's nice to kind of start with this idea of hematopoiesis, the myeloid arm, the lymphoid arm, and the fact that immature cells are called blasts, right? That's kind of where we are right now. So if immature cells are called blasts, then you can have myeloid blasts or lymphoid blasts, depending on where you are in this pathway. So today we'll be covering pretty quickly in 50,000-foot view, acute leukemias, chronic leukemias, myeloproliferative disorders, lymphoma, and plasma cell disorders. But remember that this isn't an exhaustive list. It's a pretty quick, high yield type of review for step one. There are obviously myelodysplastic syndromes as well, which we won't be covering today. There's some overlap syndromes, but in general, those don't tend to be super high yield for a step one review. And so hopefully by an understanding of this outline, you'll be able to kind of piece together anything else that we don't touch upon today. So let's start with acute leukemia. So I don't know if you've ever kind of heard about someone having an acute leukemia, right? So there's a difference. The leukemia, just leuk means white and emia is blood. So leukemia basically means that there are white blood cells in the blood, or increased white blood cells in the blood. So that could be, you could have increased white blood cells in the blood because of an infection. You could have them because of a variety of reasons. Sometimes when you take some medication, you can have an increase in those. But an acute leukemia is a malignancy, right? And so this acute leukemia is a malignancy, and it's defined quite simply by the fact that there needs to be an increase in the number of circulating immature cells, which we already defined as blasts. Now, if these blasts are increased in the bone marrow or in the blood, and the magic number is 20%, if they're more than 20%, you call it acute leukemia, right? Notice I'm not saying acute myeloid leukemia or acute lymphoid leukemia, because we're not talking about whether they're myeloid blasts or lymphoid yet. We're just saying that if there's 20% blasts or more, it's an acute leukemia. Now, for those of you who are kind of lovers of hematopathology, you'll understand that there are other ways to get to the term acute leukemia. For example, certain cytogenetic abnormalities can get you to this diagnosis. In some cases, even less than 20% can work. But I think for the purposes of a step one review, what you need to remember is that all of a sudden, the number of immature cells or blasts has crept up, and it has hit the number or surpassed the number of 20%. So when that happens, the bone marrow obviously becomes overcrowded, and this overcrowding, because normally you only have around less than 4 or 5% blasts in the bone marrow at any given time. What's happening is that they quickly differentiate into more mature cells. So the number of blasts is typically not more than 3 or 4%. In some cases, it's like 1%, and that's totally normal. So now we have 20% blasts in the bone marrow or in the blood. The bone marrow becomes overcrowded. That overcrowding leads to, really spacing out of normal progenitors that would have made red blood cells. And as a result of that, you have anemia. Those cells that would have made platelets, the megakaryocytes. And as a result of, pushing those out, you have thrombocytopenia. And you also push out all the granulocytic cells, or the ones that would have made neutrophils, and so you have neutropenia. So patients will present with tiredness because of anemia, bruising because of thrombocytopenia, and increased infections because of neutropenia. If the bone marrow kind of obviously overflows with these blasts, they do leak out into this bloodstream, and they basically are now floating around as well. So you get an increase in your white blood cells. So the patient will have a leukocytosis. They can either be defined by having 20% blasts in the bone marrow or 20% blasts in the blood. If that happens, this is a malignancy. It is known as acute leukemia, right? So acute leukemias, as we've just discussed, now depending on what the blast is, right? If it's a lymphoid blast versus a myeloid blast, you can sub-differentiate acute leukemia into acute myeloid leukemia, which is on the right here, or acute lymphoid leukemia, which means that if we study the blasts, if we phenotype them, right, study what's on their surface, study what is inside their, kind of their DNA, the genetics. If they are falling into the myeloid category, it'll be AML. And if they fall into the lymphoid arm, it'll be ALL, right? ALL obviously can be defined further by whether it is going into the Ts, right? The T cells, which would become T lymphoblastic leukemia, or T acute lymphocytic leukemia, or B ALL, right? And so depending on whether you have B markers or T markers, you can call it B acute lymphoblastic leukemia or T lymphoblastic leukemia. In the myeloid family, there's several different types of leukemias that you can have, right? So you should know that AML would mean more than 20% blasts, and they're of myeloid lineage. But specifically, there are 3 subcategories that are worth mentioning here. One is acute promyelocytic leukemia. The other one is acute monocytic leukemia. And the third one is acute megakaryocytic leukemia. Acute megakaryocytic leukemia is when the megakaryocytes are immature. So they're megakaryocytes, and that's how the leukemia forms. A monocytic leukemia, if you remember from the arm of myeloid cells, there's an arm that goes down to become monocytes. If the blasts are monocytic, then it's a monocytic leukemia. And we'll talk a little bit about APL, or acute promyelocytic leukemia. When we think of ALL, or acute lymphocytic leukemia, you will think of certain things being positive. There is an immaturity marker called TDT. This is an enzyme that is expressed very early on in lymphoid development. TDT being positive is a good sign that something is immature, right? So that's positive, and so that you can kind of look out for that for an ALL. Now, if, for example, you are defining whether something is a B or a T lymphoblastic leukemia, you're going to look for the markers that will define it as B or T. Commonly for the Bs, you look for CD10, CD19, okay? And for the Ts, you look for CD3 or CD4 or CD8. Remember that T cells are all CD3 positive, and mature T cells are either CD4 positive T helper cells or CD8 positive cytotoxic T cells, right? And so if you get that CD3 positivity, you will start thinking towards the T arm. Remember that BALLs, B as in boy, are most common in children, and they frequently spread to the scrotum and the CSF. So the CSF and the testicular tissue are both beyond, they have barriers, right? You have the blood-brain barrier and the blood-testicular barrier. So the B lymphoblastic leukemias can actually harbor in the CSF or in the testicular tissue. And this is because the barrier prevents chemotherapy from going into those sites. And so patients with BLL can sometimes get intrathecal chemotherapy, or they can even get intrascrotal chemotherapy to try and avoid the lymphoblastic leukemia being harbored in those sites. The T-ALL, as you remember, the thymus, which is in the mediastinum, is responsible for T cell development. And so typically patients with T-ALL will present with thymic or mediastinal masses, and it'll be in the teenagers. This is a picture of acute lymphoblastic leukemia. You can see that these cells have high NC ratio. They have very little cytoplasm. This one doesn't even have any, like a tiny bit over there. And they have prominent nucleoli, and they have this smudgy kind of purple-looking chromatin. In contrast, myeloid leukemias are defined specifically by the presence of the enzyme myeloperoxidase, or MPO. Now, if MPO is positive, that is a good sign that this is AML. And if our rods are present, which we'll show you some images of, our rods are defining for the fact that this is an AML. So if, for example, you just look at a blood smear and all you see are sheets of blasts, you can say if it's more than 20% that this is an acute leukemia, but you will need to study the cells by flow cytometry or other methods before you can say AML or ALL. But if you see an our rod, you can look at it and go, yeah, this is AML, right? Because our rods can be defining for myeloid disease. AML typically happens in older adults. The subcategories that we described, two of them are now shown here. APL, which is acute promyelocytic leukemia, is known because of the fact that it's a very unique AML. It's an AML which is potentially treatable. So patients can get this vitamin A kind of base therapy called ATRA. It's all trans retinoic acid therapy. The patients can get ATRA and actually go into complete remission, which is incredible. But it's an emergency because if they're not treated pretty quickly, they can go into DIC, or disseminated intravascular coagulation. The thing you need to remember about APL is that the defining cytogenetics are translocation 1517. 1517 leads to the translocation of PML and RARA. PML stands for promyelocytic leukemia, so it's pretty easy to remember because it's acute promyelocytic leukemia. And RARA stands for retinoic acid receptor alpha, okay? And that you can kind of remember because ATRA is a therapy, and that's all trans retinoic acid, right? And so it's kind of easy to remember. So think of APL. APL is one of the AMLs. It's defined by 1517 translocation, which leads to the rearrangement of PML-RARA. It can lead to DIC pretty quickly in patients, and patients can de-escalate pretty fast. But if you give it this vitamin A-based chemotherapy of ATRA, they can go into remission. The other AML that we talked about on this slide, which is acute megakaryoblast leukemia, the connection you need to remember there is with Down syndrome, because patients with Down syndrome can have an increased chance of acute megakaryoblast leukemia. In contrast to the image here on the left, which was ALL, this is the AML picture. There is a little bit more cytoplasm. You can see much more prominent nucleoli, and this arrow is pointing to an hour rod, right? And so the hour rod is a great way to make sure, certain that something is an AML. So in contrast to acute leukemias, which were defined by having 20% or more blasts in the blood or the bone marrow, now we'll move to the chronic leukemias. The chronic leukemia, right, basically means that there is an increase in the number of circulating white blood cells, but it isn't going to be blasts, or the majority of them will not be blasts, right? That's what differentiates it from an acute leukemia. So when you think of chronic leukemia, broadly think about the fact that this just means that there are white blood cells roaming around in the blood, and there are four very important differential diagnoses for increased numbers of white blood cells in the blood that are not blasts, right? Remember, they're not blasts because it's not acute, it's chronic. The first one is chronic lymphocytic leukemia. Chronic lymphocytic leukemia is actually a lymphoma. It's a mature lymphoma. These are not immature cells, they're mature cells, and they're floating around in the blood. So in one way, you can say that CLL is a mature lymphoma, but it's in leukemic phase. So the patient's lymph nodes will also be packed, but the cells are all spilling over into the blood. The thing you need to remember about CLL is that the CD20 positive B cells, CD20 is a marker for B cells, have the aberrant expression of a T cell marker. In this case, it is CD5. So CD5 is normally a T cell marker, but in the cases of CLL, it is aberrantly expressed. So if you have CD20 positive B cells that aberrantly express CD5, one of the differentials is CLL. If the patient has lymph node involvement at the same time, which is usual, you call it small lymphocytic lymphoma, or SLL, right? So CLL, SLL, interchangeable diagnosis. In fact, when I diagnose someone, I call it CLL/SLL. It's the same disease. CLL just means it's in the blood, and SLL means it's in the lymph. Really, the disease is just one disease, depending on where it presents. The thing you probably should remember is that this presents with smudge cells in the blood smear. So when you see blood smear, like lots of cells that have burst, that's kind of a classic presentation for CLL. If these cells, which are all small, transform into a large cell lymphoma, in the case of CLL, it's known specifically as a Richter transformation. So a Richter transformation is a transformation of CLL to a diffuse large B-cell lymphoma. In contrast to chronic lymphocytic leukemia, which was actually a lymphoma like we just discussed, chronic myeloid leukemia is a malignancy of the myeloid cells in which you have a spectrum of maturing cells. Lots of different cells. There's some blasts, a few blasts, right? Nowhere close to 20%. Then mature myeloid cells like promyelocytes, myelocytes, metamyelocytes, bands, all of these cells that are coming out into the blood. The defining feature of chronic myeloid leukemia is translocation 922, which allows the rearrangement of BCR and ABL1. Okay, BCR ABL being joined together leads to a constitutively active tyrosine kinase, and this constantly phosphorylates in a way that the cell keeps driving into proliferation, and as a result of that, there's a ton of proliferation, and these patients present with many white blood cells in the blood. One of the findings is that there are increased basophils or eosinophils in this case as well. And if the number of blasts creeps up a little bit, right, gets closer to 20%, CML can transform into acute leukemia. And the blasts can either be myeloid type or lymphoid type. So CML can actually go into AML, or it could also go into ALL. Next up is hairy cell leukemia. Hairy cell leukemia is also a lymphoma, similar to CLL, but it's floating around in the blood. And it's known characteristically because of the cytoplasmic projections that are on the lymphoma cells, and that make them look hairy. Now, what happens in this case is that the stain TRAP is positive. So you remember TRAP with hairy cell leukemia. And the dry tap that we are mentioning here is that when these patients are typically undergo bone marrow, the cells in the bone marrow are all stuck together. So when they're trying to aspirate them from the bone marrow, it doesn't come out. And so what comes out looks like it's dry. It looks like the bone marrow is dry, but actually it's because the lymphoma is all packed together. Adult T-cell leukemia lymphoma, or ATLL, is also a lymphoma that is floating around in the blood. These are CD4 positive T cells, and the characteristic association you should remember is with HTLV1 infection. Okay, HTLV1 infection leads to ATLL. Last but not least, floating around in the blood when you have a lymphoma called mycosis fungoides. Mycosis fungoides is a T-cell lymphoma. It is a skin lymphoma. And what happens is that these are CD4 positive T cells, and they have what we call cerebriform nuclei. What that means is that they look like little brains. Okay, and I'll show you a picture. In the skin, they are known characteristically by these microabscesses that form within the epithelium. They're known as Portrier's microabscesses. And when these cells, this T-cell lymphoma floats around in the blood, it is known as Sézary syndrome. Okay. So let's pause for a second. What have we done so far? We looked at acute leukemias. Acute leukemia needed 20% blasts in the blood of the bone marrow. It could be AML or ALL, and we talked about some features of that. Now we've moved attention to the chronic leukemias, which by definition means that there are no circulating blasts. It just means that there are white blood cells that are floating around in the blood, right? Now what you're looking at is really many of those are lymphomas, mature lymphomas that float around, right? We've given you the example of CLL-SLL. Let me show you a picture of CLL-SLL. These are the characteristic cells of CLL floating around in the blood. There's some smudge cells here as well. And when you look at the nuclei of these CLL cells, they have what we call a soccer ball appearance. So the chromatin looks like a soccer ball. Many people use different terms. You can call it pepperoni pizza. You can call it cracked earth. Some people call it soccer ball. I mean, the point is that they have these cells. Chronic myeloid leukemia, like I told you, is basically a bunch of cells all in different phases of maturation, but no great increase in blasts. Remember that these are the chronic leukemias. Hairy cell leukemia was TRAP positive, gives the patient a dry tap, and these cytoplasmic projections look like there are little hairs sticking out of the cells. ATLL can give you these flowery cells. They look like little flowers. And remember that this is because of HTLV1 infection. Mycosis fungoides is a T-cell lymphoma that also gives you cerebriform nuclei. So it looks like it's a little bit of a brain. And remember that this is a skin lymphoma, which is a T-cell lymphoma, and this can give you Portrier's microabscesses. And so here's the epithelium, and you can see this big microabscess over here, and this is associated with mycosis fungoides. When mycosis fungoides comes into the blood, it is known as Sézary syndrome. All right, how are we doing with time? So next up are the myeloproliferative disorders. As the name suggests, this is a proliferation of myeloid cells, right? So you'll tell me, well, Dr. Mirza, we just talked about, chronic leukemias. Aren't those myeloproliferative disorders? And you'd be right. The chronic myeloid leukemia is actually a myeloproliferative disorder. The rest of the ones that we looked at on this slide, the CLL, here, the hairy cell leukemia, the ATLL, and mycosis fungoides are all lymphomas. So they're not myeloproliferative disorders, they're lymphoproliferative disorders, right? The only myeloproliferative disorder we talked about was CML, right? 922 translocation, BCR-ABL1 can transform into ALL or AML. But if we go to pure myeloproliferative disorders, you think of CML, which we've already covered, but now we're going to talk about some other ones. So here we've already discussed CML, so we're not going to touch it. But otherwise, CML is a proliferation typically of granulocytic cells, right? But we have other cells in the blood too. What if we have an increase in the red blood cells? If there are lots and lots of red blood cells proliferating, it's known as, and if it's malignant, it's known as polycythemia vera. If you have lots and lots of platelets proliferating, it's the disease is known as essential thrombocythemia. And if you have an increase in megakaryocytes in the bone marrow, but specifically if you have bone marrow fibrosis, it is known as primary myelofibrosis. And the thing I want you to remember about this is that the underlying cause of CML, which we've already talked about, was BCR-ABL1 translocation, right? The 922. But by and large, for the rest of these three, you need to look for a different type of genetic change. So here we're highlighting JAK2 because JAK2 is probably the most common one, right? So JAK2 mutations underlie a lot of the myeloproliferative disorders. But for those of you who know a little bit of hemopath, you'll know that there are other ones like calreticulin, MPL, other mutations as well. But again, high yield would be that for the non-CML myeloproliferative disorders, probably the most common rearrangement genetically is JAK2. So myelofibrosis presents with bone marrow fibrosis, right? And so the marrow space is normally just filled with beautiful hematopoietic cells, but when you develop fibrosis in the space, a lot of bad things kind of happen. And one of the things that happens is that the red blood cells, when they're coming out from this fibrotic marrow, there's actually extramedullary hematopoiesis. And a cardinal feature of this will become that they become teardrop-shaped cells, right? So you can see these teardrop cells. Those are known as dacrocytes. So we already discussed some lymphomas, but we discussed most of those lymphomas in the setting of chronic leukemia, right? Meaning that they're floating around in the blood. Although we did talk about SLL, which was a lymph node-based lesion. Lymphoma, when you think about it, can either be a Hodgkin lymphoma or a non-Hodgkin lymphoma. This always kind of irks me because, like celebrities get lymphoma and lymphomas and they say, oh, I have non-Hodgkin lymphoma. Non-Hodgkin lymphoma can be like 100 different types of lymphoma. Okay. So not all lymphomas are created equal, but by and large, like historically, we think of lymphomas as either being Hodgkin lymphoma, which is on the left here, or non-Hodgkin lymphoma, which I'll kind of show you in a second. Hodgkin lymphoma has four subcategories: the nodular sclerosis classic Hodgkin lymphoma, the lymphocyte-rich Hodgkin lymphoma, the lymphocyte-depleted Hodgkin lymphoma, and the mixed cellularity Hodgkin lymphoma. I don't think you need to know too much about the different subtypes, but we will touch upon them just so that you have an idea. The non-Hodgkin lymphomas are a variety of lymphomas, and they're listed out here. We can touch upon follicular lymphoma, mantle cell lymphoma, marginal zone lymphoma, SLL, which we've already talked about, right? CLL, SLL, Burkitt lymphoma, and DLBCL, or diffuse large B-cell lymphoma. So when we think of Hodgkin lymphoma, right, the first kind of categorization of lymphoma, I typically think of nodular sclerosis classic Hodgkin lymphoma. Hodgkin lymphoma should make you think of this particular type of cell, right? Now, if we were in an interactive environment, I would have asked you, what's the cell? But you should be able to look at the cell and go, looks like a large cell, looks like it's got a binucleated appearance, looks like it's got two very prominent nucleoli. And when you look around it, you can see an eosinophil. So you're like, okay, could this be a Reed-Sternberg cell? And if you thought that, you would be correct. And a Reed-Sternberg cell is the pathognomonic or hallmark feature of Hodgkin lymphoma. And the other feature of Hodgkin lymphoma is the fact that this Reed-Sternberg cell is typically CD30 positive. So you need to remember that Hodgkin lymphoma cells or Reed-Sternberg cells are CD30 and typically CD15 positive. Nodular sclerosis classic Hodgkin lymphoma is categorized histologically by the presence of these cells. But if you look at it low power, you have these bands of fibrosis. And these pink bands of fibrosis that you can see here, they start dissecting the lymph node into nodules. So you see these pink bands of fibrosis. And what's happening is because of those, the lymphoid tissue is becoming nodular. Can you see that? Because the bands of sclerosis are all around it. So put all those words together, nodular sclerosis, classic Hodgkin lymphoma, right? So you have nodules bound by sclerosis. And when you look at high power, you'll see Reed-Sternberg cells, which are CD30 positive. Here are those Reed-Sternberg cells that would be CD30 positive if we stained them. The quick things you may want to know is that lymphocyte-rich Hodgkin lymphoma has the best prognosis. Lymphocyte-depleted Hodgkin lymphoma is associated with HIV and has the worst prognosis. And mixed cellularity typically has many eosinophils, although all of them have eosinophils, and so it's just kind of a mixed cellularity. So that was what we wanted to touch upon in Hodgkin lymphoma. Now, in the non-Hodgkin lymphoma world, there's a few things that I want you all to remember. Follicular lymphoma is an expansion of the follicles of a lymph node. These are neoplastic follicles, and this occurs because of translocation 1418. Translocation 1418 causes the overexpression of the anti-apoptotic protein BCL2. Now, if there is an anti-apoptotic protein, that means that it stops apoptosis, right? That means that it stops cell death. So when you have too much of it, it's stopping all cell death. So lymphocytes are not dying. Now, normally, those self-reactive or abnormal lymphocytes in a lymph node should die. They should undergo apoptosis so that they don't become a malignant proliferation. But in the case of 1418, that translocation leads to overexpression of BCL2. And that causes the follicular lymphoma. So here is the normal follicles surrounded by these mantle zones. But in contrast, you have, this is follicular lymphoma. The follicles are neoplastic. They're all touching one another. That's just that, they have attenuated mantle zones. It's not right. The other feature that you should remember is that normal follicles have these clear spaces. Can you see this? Like a starry sky. So they have like little clear spaces, and those are the histiocytes. And the absence of those histiocytes is also a good feature for follicular lymphoma. In follicular lymphoma, the follicle doesn't have those clear dots. This is normal. This is follicular lymphoma. Mantle cell lymphoma is next up. This is because of 1114 translocation that leads to cyclin D1 overexpression. Cyclin D1 overexpression is a characteristic feature of mantle cell lymphoma. Marginal zone lymphoma typically happens in epithelial sites, and one of the translocations associated with it is 1118. You can also have this in the setting of chronic infection, such as H. pylori in the stomach, can lead to a MALT lymphoma or a marginal zone lymphoma of mucosa-associated lymphoid tissue. So it's mucosa-associated lymphoid tissue, and this can happen in the stomach, and it can also be associated with autoimmune conditions. Burkitt lymphoma is known by its overexpression of MYC. Its association with EBV in its endemic form, right? That's the characteristic African child with a jaw mass. And in the sporadic form, it will be in the abdomen. Now, 814 translocation, 8 is MYC. There can be multiple different translocations of MYC, but 814 is the one which is probably the highest yield. This is a highly proliferative MYC overexpressing high lymphoma that basically has those forms. This is what it looks like. It has those the starry sky appearance here that you can see. You can see dark blue, and then within the dark blue, you have these white kind of clear stars. Those stars are those same macrophages that are cleaning up the debris, and so that's a very characteristic feature of Burkitt lymphoma. Diffuse large B-cell lymphoma, in contrast, has diffuse sheets of large cells, and this can actually be a de novo lymphoma that shows up as DLBCL, or it could be the transformation of a low-grade lymphoma to diffuse large B-cell lymphoma. Last but not least, we will talk about plasma cell disorders. So as we discussed already, plasma cells are terminally differentiated B cells. Typically, they will present when you have in your SPECT, you have an abnormal protein secreted in the gamma region, right? And so plasma cell dyscrasias can either be multiple myeloma, they can be monoclonal gammopathy of undetermined significance, or they can be Waldenstrom's macroglobulinemia. But remember that Waldenstrom's macroglobulinemia really is a B-cell lymphoma known as lymphoplasmacytic lymphoma, but it produces a lot of immunoglobulin, and so it can come under the umbrella of plasma cell dyscrasias. Multiple myeloma is caused by a malignant proliferation of plasma cells in the bone marrow. Here are the plasma cells. They typically are eccentric nuclei with basophilic cytoplasm. You can see them in sheets in the H&E stain, and this is likely a CD138 stain, which highlights plasma cells. They're defined by the CRAB criteria. Patients should have elevated calcium, renal abnormalities, anemia, and lytic bone lesions. The hypercalcemia is because plasma cells activate the RANK receptors, or the RANK receptors, which are on osteoclasts that cause the resorption and increase in calcium. The renal abnormalities lead to renal failure. Patients have increased creatinine and proteinuria. And remember that patients are at a very elevated risk for infection, and often infection is the cause of death in these patients and not the myeloma itself. Myeloma can lead to lytic lesions. The albumin globulin ratio is all kind of whack. And so because of that, you have this very robust rouleau formation in the blood cells, which all the RBCs stack up like a stack of coins. You have deposition within the glomeruli of the kidney of immunofluorescent material. These are just glomerular stains. And remember that, the CRAB criteria require like an anemia and also their Benz-Jones proteins. So here you can see that there is proteinuria in the urine, right? And so those are Benz-Jones proteins leaking. So now with this kind of broad and quick, 40-minute overview that we did of the major 50,000 foot kind of diagnoses within heme, we're going to do some board style questions together, right? So I'm going to try and open the chat and see. Okay, nothing in the chat. All right, so here's a question. A 45-year-old male presents with fatigue, night sweats, and splenomegaly. A peripheral blood smear is shown. Which of the following genetic abnormalities is most likely responsible for these findings, right? So when you take a look at this, you say, okay, on this side, you're seeing this particular cell, which is unusual. And on this side, you're seeing different types of cells. And so you have to come to some sort of a conclusion pretty quick. So here, what my first thought would be is that there is a red blood cell that's nucleated on the left, and there are teardrop cells on the right. Let me look at the chat. Okay. All right, so people are guessing. Very good. So really quickly from what we've learned, 922 would be CML, right? BCR-ABL. Does everyone remember that? Does this look like CML? No. Chronic myeloid leukemia would have increased numbers of white blood cells. So that's number one. JAK2 mutation, what did we call JAK2 mutation associated with, right? JAK2 mutations were associated with myeloproliferative disorders, of which one of them was primary myelofibrosis, right? And so when it's primary myelofibrosis, you can get these teardrop cells and these nucleated red cells. And so that is actually the right answer. It's JAK2, right? But I'll keep going. BCL2 mutation is actually not really part of any of the things that we discussed. Remember, BCL2 overexpression has been discussed, and BCL2 translocation is part of follicular lymphoma, but BCL2 mutation is actually not one of the things we've discussed so far. 1114 translocation can be associated with different things, but again, that's not relevant to this particular case. And the hemoglobin beta chain is also not relevant. So the answer is JAK2 mutation because of the fact that there is what we call a leukoerythroblastic picture. You have dacrocytes and nucleated red blood cells. This is associated with myelofibrosis, right? So next question, a 60-year-old female presents with lymphadenopathy, fever, and weight loss. Biopsy of an enlarged lymph node with CD15 stain is shown. Which of the following portends a worse prognosis, right? So immediately what this means is that you should be able to look at this large cell with the binucleate appearance, and it's CD15 positive. And so now it's already assuming that you know what the diagnosis is, right? And so if I'll read off the answers. Is it bands of sclerosis dividing groups within affected lymph nodes, right? Is it numerous lymphocytes within the affected lymph nodes? Is it numerous eosinophils within the affected lymph nodes? And is it very few lymphocytes within the affected lymph nodes? All right, I love this. People are answering questions. Excellent. Very nice. So it's very few lymphocytes. So lymphocyte 4 would be the ones which has the worst prognosis. Good job. And so the other question is, what other marker do Reed-Sternbergs normally express? Excellent. Wonderful. I love that you guys are answering here. That's fantastic. Good job, everybody getting it right. Okay, so this is CD30. That's the right answer. So it is weird that we started you with CD15. That's normally not what we start you off with, but CD30 will be positive. Good job. I'm proud of you all. So an increase in which cell type is most likely to be seen on this patient's CBC. So this is a really bad looking image, but sometimes bad pictures come. And so you'll have to kind of figure out what it is that we're trying to show you, right? But if you look here, you can kind of see that maybe this is a binucleate type of large cell with prominent nucleoli, right? And so what would we see? Would we see neutrophils, basophils, eosinophils, platelets, or monocytes? And no one's answering this one, because you're still stuck. Okay, there's a good, all right, very good. Basophils could be one, eosinophils could be the other. Very good. All right, platelets is also not a bad choice. So I would actually say that, everyone who said basophils, I don't disagree with you. I think that that would be totally appropriate to think about, because this is basically classic Hodgkin lymphoma. It can give you basophils, but the right answer is eosinophils, because eosinophilia is associated with Hodgkin lymphoma. So remember that classic Hodgkin lymphoma is associated with eosinophilia. Basophils can be increased, but if you ever to see a question like this, you should think of EOs. This was an interesting one. 25-year-old woman presents with fatigue, weight loss, and night sweats, right? So she seems to be having these symptoms, which is weight loss and night sweats. Examination reveals lymphadenopathy and hepatosplenomegaly, and this is a biopsy of an enlarged lymph node. Which of the following translocations is characteristic of the neoplasm seen in this patient? Okay, so the answers are coming in. Let's take a look. All right, so people are thinking 1418. So 1418 would be what? 1418 would be follicular lymphoma, right? And follicular lymphoma doesn't seem to be the right answer here because there are no follicles. This is 814. Why is this 814? Let's talk about that for a second. Very good. It's 814. Superb. 814 because this is Burkitt lymphoma, right? Burkitt lymphoma is that characteristic starry sky appearance. You can see sheets of cells with these clear cells in between. And then we go on to ask, what is this marker that Burkitt lymphoma overexpresses? Very good, folks. Everyone's kind of getting the answers right. Good job. So what Burkitt lymphoma overexpresses what marker? Specifically. Very good, Mick. Excellent. So this is the Mick stain, and this is Mick is overexpressed. Good job, folks. Really loving this interaction. You guys are ready. An otherwise healthy 70-year-old male presents with bone pain and elevated serum calcium levels. So immediately you should be able to say, okay, something is happening, which is kind of like within the plasma cell range, right? A serum protein electrophoresis study is shown, and you can see here the gamma region, you have this huge M spike, right? What is most likely to be the patient's eventual cause of death? Is it metastatic spread of malignancy? Is it infection, pulmonary embolus, or myocardial infarction? Very good. You guys are on top of it, all right? It's infection, which we talked about already. Very good. This is a 19-year-old college student who presents with a sore throat, fever, and fatigue for the past week. Physical examination reveals cervical lymphadenopathy. A peripheral blood smear is shown. Which of the following viruses is most commonly associated with these findings? So if you take a look at this, you see these lymphocytes that have this, what we call a skirty cytoplasm, lots of floppy cytoplasm everywhere, right? And this is a very characteristic feature. These are atypical lymphocytes, right? So is it HIV? Is it EBV? Is it CMV? Herpes simplex, or varicella zoster? I love it. BBB. Zach says BBB. Perfect. Yes, it is B. Very good. All right. Excellent. It's EBV infection, right? So this is infectious mononucleosis, and those are your atypical lymphocytes. For the heme nerds like me amongst the audience, those are known as Downey type. Very good, Zach. Downey type 2 cells. Okay. So what should this patient avoid for at least 1 month? This is the patient with EBV. So I'm trying to answer some questions. Very good. I love how everyone knows this contact sports. Geez, very good. Does CMV have findings on blood smear? Actually, CMV may not. Cytomegalovirus does have, if CMV infection in tissue can give you very characteristic features, but in the blood, typically, it'll probably look similar, but not exactly the same. All right, and this patient may develop a rash if given what antibiotic? Very good. You guys really know this. I'm sorry, Zach. I'm going to write to your parents. That's not good, but I'm glad that you're okay. All right, amoxicillin, very good. Ampicillin, right, is the one. And EBV association is with Burkitt lymphoma, especially in the case of the endemic form of Burkitt lymphoma. But this is not Burkitt lymphoma, just to be clear. Remember that the infection with EBV is something that all of us has probably had, right? Infectious mononucleosis, known as the kissing disease, when people kind of exchange saliva or like cough in each other's faces or whatever it is. But the point is that that is just EBV infection. If you have an immune system that is working, you just fight that infection, you'll be okay. But in cases where you have immune suppression, you can get EBV infection. And what EBV does is that it can actually go in to the B cell, infect the B cell, and then become part of the genetic machinery of the B cell. It can overtake the B cell, and then it can lead to a B cell lymphoma. So there are some B cell lymphomas that are associated with EBV infection, and Burkitt lymphoma is one that you should remember. All right, a 7-year-old child presents with fever, pallor, and easy bruising. Lab investigations reveal leukocytosis with the predominance of lymphoblasts on the peripheral blood smear. Flow cytometry analysis of the peripheral blood demonstrates expression of TDT, CD10, CD19, 20, and 34. A bone marrow biopsy confirms the diagnosis of B-cell acute lymphoblastic leukemia, or BALL. Which of the following genetic abnormalities is most commonly associated with BALL in children? Now, remember in this, actually, one of the tips is that you can actually just read that last line. Which of the following genetic abnormalities is most commonly associated with BLL? And that's all you need to know. All right, so we have some options for B, some for D, right? So you're right. So for D and E, I can say that you can absolutely have hyperdiploidy or hypodiploidy, but which one is the most commonly associated? And the most commonly associated one is the ETV6 RUNX1 fusion, or the 1221 BALL, and that has a good prognosis. And remember that BALL with 922 typically happens in adults, and that has a poor prognosis. Right, really very good. All right, 55-year-old male presents with long-standing history of pruritic erythematous patches and plaques on his trunk and extremities. Despite various treatments, the lesions have persisted and progressed over several years. A peripheral blood smear from the patient is shown. A skin biopsy of this patient's lesions would show a dense infiltrate of cells that express what marker? So what you have to kind of tell me is that what are these lymphocytes, right? Are they a lymphoma? And if they're a lymphoma, what we're basically asking you, is it a B-cell lymphoma or a T-cell lymphoma? Very good. So all those writing CD4, right? Because immediately a skin biopsy, you think of a T-cell lymphoma, right? T-cell lymphomas happen in the skin. So remember, we talked about the cerebriform nuclei, or like these convoluted nuclei. So now we're looking at the list. CD4 is the only T-cell marker, and actually it's positive in Sézary syndrome or mycosis fungoides. 19 is a B-cell marker. 8 is a T-cell marker, but it's not the one known for in mycosis fungoides. CD34 is an immaturity marker in endothelia and an endothelial cell marker, and MPO is a myeloid marker. A 55-year-old female presents with easy bruising, recurrent nosebleeds, and fatigue. Physical examination reveals petechiae and ecchymosis. Peripheral blood smear shows numerous blasts shown below. The patient is at risk for developing what condition? So first you look at these and you see lots and lots of hour rods. Can you see them? Hundreds of hour rods. So many. So immediately the first thing you have to do is you have to figure out what type of AML it is, right? So immediately everyone is saying the correct answer. It is B. But remember, first you've diagnosed this. So you've diagnosed this as APL, acute promyelocytic leukemia. So the answer is DIC. The patient can go into DIC very quickly. Do you remember what the translocation was? I'm waiting for the chat. Very good answer. The ATRA is the answer, 1517. Fantastic, all of you. It's 1517, that's PML RARA. You give the patient ATRA and the patient gets better. Otherwise, the patient can die of DIC. So what's the best screening test for DIC? What would you do? What test would you do in the patient's blood? Yeah, PT-PTT isn't a bad idea. D-dimer is the answer. Very good. The hour rods that are present, what are they made of? You can see lots of hour rods here. Excellent. So that is the right answer. MPO is what they're made of, but think about it. They're actually made of the granules that contain MPO, but MPO is definitely very good, Sabra. The granules is also the answer, but MPO is what you need to remember. And which vitamin's derivative is given to this patient? Very good, Corey. You guys are on it. A, very nice. And you've already told me the translocation is 1517 and RARA. Okay. A 65-year-old male presents with fatigue, unintentional weight loss, and large lymph nodes in the neck and axilla. Lab investigations reveal lymphocytosis on the CBC, with the differential count showing an absolute lymphocyte count of 45,000 per microliter. A peripheral blood smear is obtained, and an image is shown below. Given these findings, what is the most appropriate next step in the management of this patient? So first of all, you need to look at this, and you need to tell me what this diagnosis is. Excellent, right? So it's smudge cell, so it's CLL, very good. So do you initiate treatment with rituximab? Do you perform a bone marrow biopsy? Or do you order a flow cytometry analysis of the peripheral blood? Or do you give them antibiotics? Or do you start warfarin? Very good, Risha, Cora. Very good. So it's C, you and Jasneet. Very nice, Sabra. So basically, you order flow cytometry analysis of the peripheral blood because what you want to do is you want to phenotype and make sure that these cells are the CLL, SLL cells, right? And so then when you phenotype them, what is the expected expression profile of CD5 and 20? Are they positive for both, negative for both, mixed with one another? Which one would it be? Eric says A. Very good. Risha says A. Fantastic. So remember, Michaela, excellent. So CD20 and CD5. So remember, I told you that CLL is a B cell lymphoma that co-expresses aberrantly a T cell marker CD5. Very good. So here's a 50-year-old patient who presents with fatigue, abdominal discomfort, and splenomegaly. Lab investigations reveal pancytopenia. Peripheral blood findings are shown. The bone marrow biopsy yields a hypocellular specimen, or what we call a dry tap. Given these findings, what is the most appropriate chemotherapy regimen for the initial treatment of this patient? So what I want you to first tell me is what the diagnosis is, because Jerome put this amazing question in, and even I didn't remember what the therapy was. So let's just talk about very good. Everyone knows it's hairy cells. Fantastic. So if you, for example, were nervous about all the red cells kind of stacking up on each other, that was just distracting. It's hairy cell leukemia. And the answer, does anyone know what the answer is? I'll be so impressed. Trap the hairy beast, Sabra. I love that. Very good. It is C. Wow, you guys are great. It's C, cladribine. Good job. So now we're going to move on to some RBC questions. Let's do. All right, we have 9 minutes left. A 40-year-old female presents with fatigue, jaundice, and splenomegaly. Lab investigations reveal an elevated indirect bilirubin. Peripheral blood smear is shown. What are the patient's expected lab values? So the first thing, very good, you guys are on it. The first thing is that there's a bunch of what type of cells are these? The ones that don't have central pallor. Spherocytes, excellent. So when you have spherocytes, you automatically know that MCHC will be increased, right? That's one thing. The other thing is that you have very small cells and you have really large cells. Can you see that? Small cell, large cell. So when you look at the variation of the MCV from small to large, that means that the red cell distribution width will be increased. So what's the answer? Somebody's already told me, right? So it's A. Very good. So the RDW is increased because you have small cells and large cells. So you have a variation in the MCV. And the MCHC is increased because these are spherocytes, and spherocytes don't have central pallor, so they have an increased mean corpuscular hemoglobin concentration. So it's caused by an inherited mutation in what? Hereditary spherocytosis. So yeah, it could be ankyrin spectrin, very good, band 3. So it could be any of the cytoskeleton membrane, right? So ankyrin spectrin. And what are they at an increased risk of? Very good, gallstones. You know why? Because they keep hemolyzing, right? And when you have hemolysis, they can keep continuing to, all of the things happen. And then what can give them anaplastic crisis? What infection? Parvo, very nice, B19. So parvovirus B19. I still can't get over I think it was Zach whose parents sent him for the context course after infectious mono. That's so funny. All right. Patient undergoes a splenectomy to resolve his symptoms. A repeat peripheral blood smear is performed. What is the composition of the structures identified by the arrows? So first of all, you need to tell me what they are. What are these little... So, everyone's saying Heinz bodies. I don't disagree with you, but they're not Heinz bodies, guys. Nope, they're not Heinz. Howell Jolly is the right answer, right? So they're not Heinz bodies, but that's actually good thought. So let me tell you a little bit about Heinz bodies. Heinz bodies are made of hemoglobin. Because they're made of hemoglobin, you won't be able to tell them on the smear, right? Because they'll just be part of the nucleus. So you can't actually, unless you do a particular stain, you can't see the Heinz body. These are Howell Jolly bodies. Very good. And so question is, what are Howell Jolly bodies made up of? Are they made up of DNA, RNA, protein, hemoglobin, or iron, right? And the answer is DNA, very good, because these are parts of the nucleus that are left over. So remember when the red cell spits out the nucleus, you get a little bit left over, that is. So what is this association with the splenectomy? The association is normally we do get these cells, but our spleen interrogates all of very nice. They can't bite it out because they don't have the spleen left anymore. And so even, Howell Jolly bodies being present is they do norm it. All right. So very nice. Zach's a funny guy. All right. So in any case, that's a good sign. This is a 25-year-old male, African descent, presents with fatigue, episodes of pain in his extremities, and jaundice. Lab investigations reveal anemia with elevated red cell count. A peripheral blood smear is shown. What is the most appropriate treatment strategy to reduce the frequency of painful episodes in this patient? So what's the, very good, very good. So everybody gets it, right? So what's the disease? Sickle cell. Fantastic. Excellent. Sickle cell anemia, you give hydroxyurea, their Howell jolly bodies, their sickle cells, and their target cells. Very good. All right, spot diagnosis. What's the diagnosis? Malaria. Very good. Can everyone guess which one? What type of falciparum? Like I said it, falciparum. All right, it's plasmodium. Yeah, it's falciparum is a type because it has, I always remember it has these like ring forms or kind of like what you call the, the headphone forms. What are these cells? Zach, it could be Babesia. Babesiosis is intracellular, but it looks more like the Maltese cross. But you'll probably have to you'll get a history most likely of where the patient is coming from, etc. Do you see malaria in real life? Yes, we do. Yep, these are helmet cells or schistocytes. Remember, schistocytes are created because of intravascular hemolysis. So when you think of intravascular hemolysis, think of blood vessels, right, with these fibrin strands. When the red cell goes through it, it shears into two. So it has these two points, right? Like which are kind of important to know. So the way I diagnose schistocytes is that 2 points and then lack of central pallor, right? And so these are schistocytes. And then what are the disease? Nasser has already said it. What are the disease associations? The microangiopathic hemolytic anemias like DIC, TTP, HUS, etc. Patients with prosthetic heart valves can actually mechanically shear because the heart valve will shear the red cells. Also, patients who go on really long marathons, sometimes they can get physical like breakdown of cells as well. So that's why I don't run marathons, because you don't want schistocytes. Just joking. All right, that was our last slide, and I'm really, really proud of all of you for really participating, even though I couldn't see anyone's faces. But it was wonderful. Hi, Nisa, how are you? You guys can find me on like social media if you have any questions. Usually I use X the most. That's my handle in case you don't know, and my DMs are open. So even if I don't follow you back, I'm happy to do it, but I'm happy to answer questions. Nisa, Jerome, and Emma, thank you so much, you BATSIG team, for putting this together.
Thank you, Dr. Mirza. That was really, really terrific. And just to remind everyone, Dr. Mirza is also doing a renal path review tomorrow at 1 p.m. Central Time. So we are always using Central Time here with PathSig. I'm sending the registration link in the chat right now. But thank you so much, Dr. Mirza. That was really, really terrific. And thank you all for your interaction. It
was really good. Yeah, honestly, like answering questions, and that too, like people were just answering in the group chat. That was spectacular. I loved it. We shouldn't feel like kind of conscious of answering questions. Everybody should be. This is how you learn. So this is great. All right. See you guys, many of you tomorrow. Cheers.